Welcome, everyone, to the LifeBulb seminar series focused on transplantation or organ transplantation. My name is Karin Nienberger. I'm the president of LifeBulb. I'm a trained physician and PhD, but I'm also importantly a transplant recipient, 3-time transplant recipient, and now living with a kidney and a pancreas. So I'm incredibly grateful to physicians like you, Dr. Pereira, and also, of course, to our sponsor for this seminar series, Roxas Pharmaceuticals. So welcome, Dr. Pereira, and please just a few words about your background and what you do at Columbia.
Sure, absolutely. And thank you so much for the introduction. Yes, my name is Marcus Pereira. I'm an associate professor of medicine here in the Division of Infectious Disease. I'm also the medical director of the Transplant Infectious Disease program here at Columbia. We're a large transplant or solid organ transplant center. We do hearts, lungs, kidney, pancreas, as well as livers. And, to support that huge endeavor, transplant infectious disease is sort of has grown in the last several years. We feel very much part of the team, and we're sometimes, unfortunately, sometimes fortunately, involved in the care of our transplant recipients here.
No, thank you. Thank you so much. And, it is, I think sometimes we see healthcare as only being involved when we're really sick. But in the case of infectious disease, it is truly more than that, because there are many things that we can do to prevent, or even when it happens, to kind of limit the consequences of the disease or the condition. I think you're in a unique position working with organ transplant patients because of the immunosuppressant therapy that we all have to be on for as long as the graft is alive. We're so grateful to the donors and to the system for giving us this opportunity to life again. There are of course limitations due to the drugs, even though I think that we all try to live life as fully as possible, which is, I think, truly the goal for everyone involved. But why don't you talk a little bit about what we can do to perhaps first prevent infections and which infections we truly should be worried about?
Sure. So that's a wonderful question. There's a lot there to discuss. And you're right that, we're in a unique position that we can sort of focus on both prevention as well as treatment and mitigation of a number of these infections, and that transplant recipients, by nature of the immunosuppressive medications that they need to be taking, are especially vulnerable to a number of infections. We have several focus sort of in terms of several areas of focus in our transplant infectious disease program. There is a preventative area where we meet a number of our transplant candidates or people who are undergoing sort of evaluation for transplant, where we spend the time talking about sort of, the nature of transplant, immunosuppression, and their overall risk to several types of infections and what we can do about that. And then we also focus on preventative measures like vaccines and medications that can prophylax or prevent certain infections from reactivating, for example, and then strategies for safe living. So obviously all of those it's quite an involved visit. It's a lot to talk about. But I think in a nutshell, so transplant recipients, their risk of infection is somewhat dynamic after transplantation, and it really becomes directly as a result of the degree of immunosuppression that transplant patients require. So many of you will know, right, that at the time of transplant, patients receive what we think is sort of more like induction immunosuppression, which is really very intense medications that kind of knock down your immune system for a while. And that's designed to already set the stage for you to prevent rejection and to allow sort of the subsequent medications, right? Sort of what we know as sort of a maintenance immunosuppression to sort of then take charge and again, try to prevent rejection as much as possible. But the risk of infection sort of somewhat varies based on that. Sort of the first sort of year, for example, that's when you have sort of the greatest risk for unique types of infections that are really sort of the hallmark of a transplant recipient. You have rare things like CMV, for example, which is a very important virus that about 50% of us adults in the United States will have, that it can be very indolent, or I should say that it's dormant in our body, and because of immunosuppression can reactivate. There are similar viruses like CMV, such as VZV, EBV, and HSV that can do the same thing. And we have medications that can prevent those viruses from reactivating. There are other opportunistic or unique infections, such as aspergillosis, pneumocystis, which is a type of infection that can cause severe pneumonia. And we also prescribe medications for those transplant recipients to receive for about 6 to 12 months after the transplant so that they can prevent these infections from reactivating.
So let me see if I understand. So the first portion, you described viruses that may already be within the body of the recipient or in the organ of the donated organ, right? So that could be, because of the immune suppression in the recipient, could be reactivated during the first period after the transplantation. So for that category, you would prescribe a so-called antiviral?
That's exactly right. That's exactly right. So some of these types of infections are either coming from the donor or are in already the recipient's body and are dormant, have been dormant for most of their lives, but now because of immunosuppression, it can reactivate and cause trouble. So CMV is sort of the prime example of that. And then there are other types of infections that actually can come from the environment, such as pneumocystis and aspergillus, that, we get exposed almost on a constant basis. But now that someone has a weakened immune system, they're more vulnerable to it. And for those, because some of those are well-known risks, we can also give medications to prevent those types of.
And are those the antibacterial drugs?
Those are the antibacterial. So a lot of transplant recipients will take a medication called Bactrim or Atovacone, for example, also known as Mepron, specifically to prevent pneumocystis. Valganciclovir or Valsite, which is an antiviral, can prevent CMV from reactivating. Yeah.
And what about fungal infections?
Yeah, so that's the third big category, right? We have viruses, we have bacteria, and then we have fungal organisms as well. So mold and yeasts are the two most common forms of fungal organisms that can infect the transplant recipient. So that's a little bit more nuanced. Most transplant recipients, it really depends on the organ being transplanted and sort of certain things that can happen during the transplant that can increase or decrease the risk factors for those. So, for example, our lung transplant recipients are at greatest risk for a fungal infection, in particular pneumonia. So we're very thoughtful about giving them antifungal prophylaxis as well, particularly in the first month. They get an inhaled medication. And depending on other things that the pulmonologist, for example, identifies during a bronchoscopy, which is, when they put a camera in to look in the lungs and make sure it's healthy and not infected or not rejecting. If they see certain things there that are concerned to them, we can also start antifungal prophylaxis, usually with an oral pill that can have a good activity against these fungal organisms.
And I remember also after transplant, you would have to gargle with a solution, right?
Yeah, so that's exactly right. Nystatin is an anti-thrush medication. So thrush is very common for a transplant recipient. Again, it's a function of immunosuppression. We all have sort of candida in our mouths, but when the immune system is not there to protect, you can develop these small white plaques in the mouth. They're sort of not necessarily dangerous, but they're certainly unsightly, and nystatin can help prevent that. Yeah.
So you kind of covered the preventative approaches and what you can do during that first period after induction, and now the patient is on maintenance, and hopefully within a year, it settles a little bit. The immune system is now, in a kind of new normal, and the patient is now looking forward to maybe traveling and going to gatherings and going back to their normal lifestyle, or where they were maybe before dialysis or before they were an end stage organ disease. So, some patients will say, I will never go to a gathering where there are lots of people. I will not go to, children's gatherings to get exposed to the little children, and some, anyway, some people will. And, what do you, obviously it's a personal choice, but as an infectious disease doctor, what do you think, how do you think you should measure that risk?
Yeah, so that's exactly, usually after the first year when someone's greatest risk for these opportunistic infections sort of dies down a little bit, it's not completely over ever, but it certainly becomes less prominent. And patients are feeling healthier or more energetic, trying, sort of ready to sort of go back to their normal lives as much as they can, that's where sort of, a different set of risks come. Like, and as you mentioned, right, you want to sort of go back to the community, travel, do things which was exactly the point of transplant to begin with, right? To have that sort of better quality of life. You're not tied down to a dialysis machine, for example, or now your heart is better functioning with the transplant and you have sort of the stamina to do more things. And I have to say, I encourage my patients to always look forward to that, because again, that's the whole point of having gone through that entire year, right? If not years of feeling unwell and going through all the process of transplantation. So that's where sort of the strategies of safe living comes into place, right? Like you sort of want to be able to always gauge the risk and match, right, with what you think is sort of the benefits of certain activities and what is really important to you, right? I think that I in particular want to be very supportive of activities, and sometimes it depends on what kind of activity and the time of the year, right? So for example, in the last 4 years with COVID, it became very hard to say it's okay to go to a closed door theater with lots of people, in particular in the middle of the winter, where I knew that my transplant recipients and patients would be at risk of either getting COVID or influenza or other respiratory infection. But, if they tell me that they're going to an open air theater, in the park on a summer afternoon, by all means, that's great, right? So I think some of it is you do have to gauge the risk, So for example, birthday parties, for young children, right? It's important to always be aware, or at least to make the rest of the group aware that, hey, I'm a transplant recipient. I'm a little vulnerable. Is it possible if anybody has a small child who's sort of sick with the sniffles and, could potentially be infectious, please let me know whether I will come or not, or whether that child is coming or not, because you do want to have that protective ring around you, family and friends and loved ones who are also watching out for the
it's interesting. It is very, I think, accepted today to say I have a nut allergy, or I have some sort of, allergies are just more prominent. And I mean, that's a different seminar, why that has happened. I remember growing up, no one had allergies. Now everyone has allergies.
Yeah.
So it's clearly something has happened in the environment or the microbiome or immune system. Anyway, but it's not as common, I think, to hear about these, that you're a transplant recipient. We have a transplant recipient in the crowd, and therefore we should keep, a person at home, or we should respect that. Maybe it's because there's so few, but it truly is a good point that you should be able to make as someone who has received an organ, has gone through so much, that please respect, that journey and do not, do this frivolously.
Absolutely. And I do think that COVID has helped a little bit. So for example, mask wearing, right? We certainly see a lot more mask wearing than we did prior to 2020 and sort of, in the West, right? Like sort of North America and Europe and so forth. So that's a positive change. I encourage my patients to always have a mask if they are in a certain situation that they're feeling a little vulnerable, in particular for someone sort of infecting them. It's important to have sort of that ability to protect themselves. But again, and feeling very comfortable in telling others, I'm a transplant recipient, is there anything, please be mindful and help. So that's sort of part of some of the assessment, right? Are you will you be able to do that, right? Like, do you have sort of a friendly crowd of loved ones who would be very receptive to that message or not, right? And you have to sort of gauge that.
And to me, that's a little bit about the number, right? Because if you're going to a group of 20, you might know everyone. If you go into a group of 100, or if you go into a concert, right? You don't know. You can't expect people to stay home. Even though it might be common courtesy, but it's just not possible to execute. Are there any particular infections that transplant patients are more vulnerable to? You mentioned COVID and influenza. Is it the case that a transplant patient will get COVID more often, more seriously, and the same for influenza? And are there others like pneumonia? Are there certain infections that transplant patients are just less able to handle, or is it just every infection?
Now, there are many infections that transplant recipients are less able to handle, right? So sort of with a weakened immune system, it unfortunately works both ways. you're more vulnerable to catching infections from others. You don't have that sort of protective barrier with your immune system as strong as before. And also, you're more vulnerable to infections within your body in terms of them reactivating. And CMV is that example. But also, once you catch those infections, a number of them will present themselves more severely, unfortunately, right? So it's sort of all of a function of that immune system, and perhaps sometimes other things, right? Like you're healing from a big surgery, or, people have other medical problems like kidney disease, for example, and diabetes and so forth. So all of those it's unfortunately a sort of a double whammy.
Yeah, it's a total, yeah.
And if you go down the list, of typical bacterial infections like a bacterial pneumonia, transplant patients are slightly more vulnerable to the common infections that everybody will get, and obviously vulnerable to the unique sort of immunocompromised type of infections. What's interesting is, that it's also, one has to have a higher sort of degree of awareness and of concern, because sometimes the presentation is not the same. And many of my patients tell me, for example, you're a kidney transplant recipient, a UTI post-transplant may not feel the same way as and the UTI meaning urinary tract infection, doesn't feel the same as before transplant, and it's because, is it because the immune system is different? You're not going to produce a fever or other symptoms, or is it because now you have a new kidney? It's really individualized, but common infections can also present differently. So I always tell my patients, you want to be very aware of what's happening with your body. Don't ignore that fever. Don't ignore that cough after certain days, or other symptoms like diarrhea or something related to a UTI. It's very important to be aware. I don't want my patients to be hypochondriacs, but I want them to be sort of at least mindful, so that they can pick up the phone.
If you had a way, obviously you as the physician can only see the patients sporadically. You can be in touch with them to a certain extent, but you have many, many patients. Columbia does 300 a year. There are a lot of patients.
Yeah.
Do you encourage your patients to keep a diary of how they feel? When it comes to, if you start feeling a little bit, I always say that before transplant, my case had type 1 diabetes, so it's also a little bit, you already had to monitor a lot. Yeah. But I think when you have a chronic illness that affects you, you start getting to know your symptoms in your body, almost like and I want to compare it to a sports car just because I like the analogy, but a sports car is more sensitive to little issues, right? If you mess up a Ferrari, it's going to not drive. If you mess up something that is simple, it's probably still going to be driving, but it never will drive as nicely. So I kind of say that's what we are. The transplant patients are, really complicated. And
I really like that. Yeah, that's great analogy.
It is, because if you mess up a little screw here or there, you have to replace it all the way from Italy, and it's hard to get that. So I think that the monitoring of individual data may be very important, because it may be it's not just, it's intra-individual versus inter-individual. And it means that it could be changes within the one patient that needs to be recognized. And, I wonder how we can encourage that. I know, again, you don't want patients to be hypochondriacs, but to me, it almost feels a safety, because there are certain symptoms that I know, I can almost ignore, because they're not going to lead to anything after a long experience if you monitor. But if you don't, then you may get surprised.
Yeah, absolutely. So we don't necessarily encourage, I don't encourage a diary, but, it's certainly a good thought, but definitely be very mindful of what's happening in your body and be very attentive. Don't ignore, and always feel very sort of free to contact your transplant providers, because that's the key, right? Sort of having that comfort in connecting with them quickly, I think that goes a long way of treating infections, in particular when it comes to infections, right? Every infection in the book is better off treated early on than letting it sort of sit there and get worse, right? So the lesson is always, something doesn't feel right, doesn't look right, pick up the phone or text your transplant providers and see if it needs to be evaluated or not, or talk to someone like me to then sort of gauge what the risk is and what should be done. So in some ways, that's sort of maybe very similar to what you're saying, sort of, just be very mindful and be very sort of thoughtful about your body and what's happening. And if something doesn't feel right err on the side of caution.
So I want to have a final take on something that is very practical. Everything you said is so great, and I'd love to have that one-on-one connection with you. But the reality is, right, we have about 250,000 kidney transplant recipients in this country, 25,000 a year. And most of them do not have a personal connection with the head of infectious disease, right, for transplant at Columbia. The reality is if you go to the ER or if you go to your PCP and you say, I have a transplant recipient and I think I have an infection, they're going to go, I don't want to know. I don't want to treat it. I don't want to deal with it. Or they put you on some sort of broad spectrum antibiotic.
Right.
So, what do you think people should do, in that case? How do we deal with that?
Yeah, it's a constant source of frustration for sure, especially with patients. Most transplant patients should have, even if they're not following on a routine basis, at least have a point of contact with the transplant team. Right. Yeah. So that's sort of by far one of the biggest connections that they should have. That's lifelong, right? Like you got transplanted at Columbia, you should always feel like that's your home medically. If something is happening, to contact, because that's the team of experts that will be able to appreciate and feel experience in dealing with, I have a fever and I'm a transplant recipient, and you're not going to get that deer in the headlight look right from like emergency care or, like you said, in an emergency room. So that's, I think, is a very important aspect of care, that, even if you moved away and you're in a different state, identify a transplant center that in a case of emergency, you can go to. I also say that for, by the way, anyone who's a transplant recipient is planning an overseas trip, by all means go there. Yeah. But if you're going to go, for example, to Italy and spend 2 weeks there, and you're going to be in Rome, identify ahead of time a transplant, a medical center that is sort of versed in transplant. So in case of an emergency, you're not scrambling, right? You know where to go, or at least tell someone that you want to go there because they have experience with transplant patients. So a little bit of homework ahead of time. But for most people who are still living in the same state, a few hours from their transplant center, that's their point of connection. And if they come to an emergency room like Columbia, the transplant centers are going to be, their transplant providers will be activated very quickly, and they can steer, the workup and the management along with the emergency room provider. So that's sort of a very important element, that, you're not orphaned, by your transplant providers. But you're right, it does require some specialized care and thinking. And the transplant providers know if there is an important question, they can reach people like me to then really help, right? Drive down the workup, the management, what to start, what not to start. Like you said, we don't want unnecessary antibiotics, antifungals. There are a lot of toxicities with a lot of those things. You really want to use when you really feel that it's going to be very important for that patient, not just because they're transplant recipients.
I think that's wonderful advice. And I think one of the, major lessons that we learned today was that prevention is really important. And it's the screenings, it's the vaccinations, it's
vaccines, right? We didn't talk about vaccines, but yes, we spend a lot of time before transplant making sure that all of our patients who are undergoing a transplant evaluation are updated with their vaccines. And we have a whole list of things that we really make sure that they get, because, the other important point is most vaccines are perfectly safe after transplant, but they're slightly more effective if you get them before transplant, because you have a better immune system to learn from that vaccine, right? And prepare that person for future. So we have a whole program that really sort of goes to each vaccine that's available and recommended, and make sure that they get. Absolutely, vaccines are important.
Great. Thank you. And I also appreciate your comment on, going back to normal life, that it's kind of an assessment case by case, but really encouragement. You really encourage patients to go back to kind of participate in normal life, or whatever is the new normal, but just be open with the situation, because most people really want to help. And most people, I think, do want to. And then I think the third point about travel, making sure when you travel that you plan a little bit extra. It's not just about not, checking your pills, but it's also about checking the destination and making sure there is some sort of transplant competency there. Yeah. And if there's not, if you intend to go to an island, you might want to reconsider.
Yeah, those are the most fun visits, by the way. We have a transplant recipient who's planning a big trip. It's sort of it's just wonderful to hear that, and
Yeah.
such a happy occasion. And we want to make sure that it stays positive, right? So we do a lot of preparation as well for those trips. So absolutely, if someone's going overseas, make sure to check in with us so that they can be better prepared.
Well, thank you so much. I think you've given a lot of good advice, but also encouraging advice. And a transplant person can live very well with their transplants without, having to experience terrible infections. Sometimes it happens, and then there are often, hopefully, remedies for that too. And those treatments need to be specified to whatever the agent is.
Absolutely.
Thank you. I hope to meet you in person soon. And thank you again for doing this for us.
Of course, my pleasure. Thank you for having me.